Wonderful. We'll let people start to gather. Right. We have our interpreter in the room. We're good to go. This is wonderful. As a reminder, before we start formally, please do feel free to put your questions in the Q&A. And when we stop for questions, we will stop the recording. So your questions will be privately discussed as a group. And so we encourage you to ask as many questions as you'd like. We're excited that you're here with us today. Okay. And I'm going to go ahead and get started. So welcome to Disability Research and Education in Academic Medicine, or DREAM Research Rounds. My name is Lisa Meeks, and I have the privilege of serving as the co-director of the Docs with Disabilities Initiative. The DREAM Research Rounds are designed in the spirit of traditional grand rounds, offering monthly sessions that spotlight groundbreaking research and dedicated research teams from around the world, all focusing on disability and academic medicine. This season of the DREAM series proudly receives support from the Johns Hopkins Disability Health Research Center. The DHRC is committed to transforming the narrative from living with disability to thriving with disability by employing data-driven and community-centered approaches. Today, I am thrilled to present our session titled A Comprehensive Program of Support for Residents with Disabilities Requiring Accommodation. It's both an honor and a pleasure to introduce our speakers today. You all know that I have a love for our Canadian neighbors, and I had the wonderful opportunity to attend a workshop they conducted at the International Congress on Academic Medicine in 2023 in Canada. I was so impressed with what they were doing that I immediately asked them to join our research rounds. Dr. Catharine Munn is a dedicated psychiatrist, educator, and researcher focusing on mental health and substance use among post-secondary students, medical learners, and physicians. She currently holds positions as the Assistant Dean in Resident Affairs and PGY at the de Groot School of Medicine and is the advisor to the Provost and Vice President Academic at McMaster on mental health. And she is also an Associate Clinical Professor in the Department of Psychiatry. Dr. Jill Rudkowski is a critical care physician, educator, researcher, and educational leader. Dr. Rudkowski currently serves as the PGY Medicine Accommodation Advisor within Resident Affairs and is the Assistant Secretary for both the Committee for Accreditation of Canadian Medical Schools and the Committee for Accreditation of Continuing Medical Education. And Dr. Nadine Abu Ghazaleh is completing her final year as a family medicine resident at McMaster University. And she's emerged as a vocal advocate for the accommodation needs of medical trainees during their clinical training. And I've had the pleasure of meeting all of these remarkable leaders, and we look forward to this discussion today. So with that, I'm going to turn it over to our presenters.
Thank you so much, Lisa, for the kind introduction. So yes, as Lisa indicated, Dr. Meeks indicated, we'll be talking today about the program of support for residents with disabilities who require and request accommodations at McMaster University in Hamilton, Ontario, Canada, located about an hour away from Toronto, Ontario, for those of you more familiar with Canada. And perhaps you can go to the next slide, Jill. I do want to introduce our team, and Lisa has done such a lovely job of introducing us just in the context of accommodations and accessibility, just to give a sense of what our roles are and how we kind of came to this work. I will say that prior to training as a physician, I undertook training as an occupational therapist, and I will say that that really informs my views in this sphere. And I think being struck as I came into medicine that perhaps not everyone understood disability in the ways that maybe I did, or the ways I thought about it, have really spurred this work on, as well as my own experiences with disability. I will so Jill Rudkowski, who Lisa introduced as well, has joined our team in resident affairs as our accommodations advisor. So while I'm one of the people on the ground actually navigating the accommodations with learners, Jill is somebody that's been more in the background in terms of helping us develop guidelines and policies, and also supporting program directors and other directions of our resident affairs office in postgrad medicine. And Nadine we had the good fortune of connecting when she came into our residency program, really at a time of transition when we were really trying to do better by residents and develop our accommodations process. And so she sort of was stuck in that kind of awkward transition phase as we tried to kind of improve and develop things better at McMaster. Carolyn Bowman's not here with us today, but she's our accessibility advisor, and we can speak a little bit more about her role as somebody with lived experience and a family physician who also offers one-to-one support with learners in our resident affairs office. And just a shout out to our fearless leader, Dr. Parveen Wasi, who's the Associate Dean of Postgrad Medicine at McMaster, who's really got this ball rolling and has championed and supported us every step of the way. So if we move to disclosures, just to say we have no financial disclosures or conflicts to declare, Jill and I both hold paid leadership positions in health sciences at McMaster, and we don't take our positions for granted as educated women in leadership and in all discussions. We wanted to preface this by saying we're going to be having a more technical discussion about the context of providing accommodations in an academic medicine setting. So we are kind of talking a rather technical language and more maybe traditional medical model, but just to say that we do embrace the social model of disability and really consider that in all of our activities. So if we move on, in Canada, we typically do a land acknowledgement at the beginning of every talk or presentation. So I would invite you to give honor and thanks to the traditional inhabitants of the land where you are right now. We here are on the lands of the Haudenosaunee and Anishinaabe nations, and these lands are protected by the Dish with One Spoon Wampum Agreement. To say this is to acknowledge a debt to those who were here before us and to recognize our responsibility as guests to respect and honor the intimate relationship Indigenous peoples have to this land. As healthcare educators, we recognize there is systemic racism within and throughout our educational and healthcare institutions, and we have the responsibility and power to create culturally safe and appropriate environments of care. So moving to the next slide, so really talking about what we're going to be talking about today. So overall today, we're going to talk about accommodations in the residency context, what we call postgraduate medical education. You may call graduate medical education in your setting. We're going to talk about a bit about the rationale for having a deliberate policy and process, and talk about how we've approached this in our area in postgrad medicine at McMaster. I think I'm going to speak more about the context, and then Nadine's going to take over and talk more about some of the barriers that residents have experienced that have informed our process really in really important ways. And then Jill's going to walk us through more of the actual nuts and bolts of our process with a case. So just to situate us here, I think it's really important, and many of you will know this already, so forgive us for repeating things you know, but we're not sure where the entire audience is at here. And we understand many of you are researchers, and in this context, we're not representing research so much as our process, which we hope in the future will be subject to more research. Really, what we have to remember with residents and fellows is that they require accommodations that are both workplace accommodations and academic accommodations, either or both, and not always both or either. And so that's a really important piece to this. It's different than, say, undergraduate students. It's different than physicians in practice, not outside of an academic setting or training program. And so they're an integral part of our healthcare workforce in Canada. And so the issues that the residents often have fallen into the gaps, so that hospitals and clinics that normally would provide accommodations to folks like nurses and others working in hospitals don't necessarily see residents as part of their role and responsibility. Academic settings sort of view residents and fellows differently, depending on which academic setting you're talking about. While undergraduate learners are often served by a university's student accessibility service, postgrad learners in Canada, Canadian medical schools, aren't always seen as being learners or students in that traditional sense, and so they often do not support residents or provide accommodations. So sometimes residents and our offices are who does this role can be unclear. And, as you all know, that we really need to base our accommodations on the functional limitations of the trainee and which aspects of their disability are causing any potential functional impairment in the workplace and the academic environment. So if we go to the next slide, I think this is something that helps us when we think about, when I think about learners and myself generally, whether or not a trainee has a disability or not, we bring with us to our jobs all of our attributes, our strengths, weaknesses, whether or not we may have a disability or difference at all. And that's what a trainee brings into the healthcare environment. We always have to really think about, well, what is the specific occupational role that trainee has in that environment? Because as you know, residency and fellowship programs are very different from one another. What's needed to be an obstetrician is quite different than the role of what's needed to be a psychiatrist. And so we have to think very specifically about what is the occupational role of that trainee. And then we always have to think about what environments are they situated in. Are we talking about the hospital? Are we talking about a clinic? Are we talking about a university academic setting? And every program's environments are different. So we have to consider all these things when we're thinking about how best to accommodate learners and create more accessible environments. So if we go to the next slide, it's thinking also about what we like to think of as the invisible stakeholders. Those are patients, and they also have to be considered in this process at a basic level. Of course, we need to have trainees that are trained within programs and environments to provide safe and responsible patient care. So that's important to consider when we're offering accommodations or thinking about accommodations. It's also really important in a broader sense to think about, well, how helpful is it for patients to see folks with visible disabilities or other disabilities that are providing care to them, and how empowering and important that can be to them. But also we have to, we have to think patients are our partners in this process, in a sense, though we don't always think of them in that way. So just to move on to McMaster and sort of just to describe our process very, very briefly, how we came to this place. So when I joined Resident Affairs as the sort of assistant dean of this office, at that time, actually, the student accessibility service on our main campus at the university was responsible for accommodations for all medical learners, including residents. And there was an SAS, student accessibility advisor, that managed those accommodations, but very few residents had ever gone to that office or sought out accommodations. And in 2021, the university determined that service was not responsible for postgrad residents. And so we undertook having to develop a policy and accommodations processes within the postgraduate medicine area and resident affairs. So together, a team of us worked on the policy and the guidelines. We developed the policy first, and then we developed a set of guidelines really to make the policy understandable. So we have two versions, and you'll see that in our guide that we've linked into the chat, or will link into the chat, and have a QR code later in the talk. We created the guidelines to explain the process both to residents and to explain the process to people that were accommodations providers. So whether that be, and that can differ based on setting. Often it's me and my team in resident affairs. Sometimes it might be program directors. So it was to teach folks to kind of translate the policy into kind of an understandable language. And that's what Jill's going to be talking about. Then we started workshops and other things to kind of bring an understanding to our supervisors and our residents about what are accommodations, and kind of set the tone, and also explain to them when they can access them and how they would access them. We're in the process now, and so we've offered a number of workshops. We were able to bring on Dr. Bowman in an accessibility advisor position, as well as Dr. Rudkowski as the accommodations advisor. And now we're in a place where we're going to be bringing on a disability services coordinator position. It'll only be 1 day a week at this point, but we're very excited to have someone whose expertise lies in this area that will be specifically devoted to the postgrad environment. So Just moving to the next slide and thinking about, well, why do we need to do this? And you may not be asking this, but sometimes people ask, well, why do we need to delve into this and get a really clear policy and process for resident accommodations? Well, I think Dr. Meek's work actually demonstrates through some that really when this was looked at in the past in 2019, only about 60% of graduate medical education handbooks actually had clear policies for requesting accommodations. So if you don't have a policy, people can't, or a transparent and clear and available policy, then people really don't know that they can request accommodations. She also in 2019 showed that just over half of family medicine residents who'd responded to a survey had disability policies that aligned with AAMC recommendations. So again, I mean, if you don't have a policy or your policy doesn't follow kind of the rules, if you will, of your province or state or nation, difficult for residents to actually apply for them and to be granted appropriate accommodations. And I think in the last study in JAMA really showed that about 50% of first-year residents who needed accommodation did not make a request. And so if we think about why that might be, and we go to our next slide, why that might be in this study was that, about 60% of the residents were afraid of fear of stigma or bias if they were to request accommodations. And about 24% of them did not feel their institution had a clear process for requesting or applying for accommodations. And so that's what we're really here focusing on. I mean, of course, it's the process. It's also through that process and thinking more broadly about these issues, hoping to reduce stigma, fear, and bias. So if we want to just think very briefly about like what's our context here in Canada, so you can kind of relate your setting to ours, it's important to note that all residency programs in Canada are directly associated with a university medical school. And so we are all governed by our university's policies and practices. And so that may differ, I know, from some places in the US and internationally. We have 17 medical schools. We have 37 entry-level residency programs, so from 2 to 5 years in length, so about 3,500 positions annually. At McMaster, we have about 1,200 postgrad trainees over 3 campuses and 25 hospitals and clinical sites. So we're kind of a mid to large medical school, and our resident affairs office we would be tasked and responsible for those 1,200 postgrad trainees. So if we think about Canadian accommodations policies, I think it's important to note that in 2018, one of our governance councils published a set of national guidelines on accommodations in residency training and assessments to make recommendations about what needed to be in place. However, if we look most recently, this is some unpublished work that will hopefully be published soon, indicated that of the programs that the 17 schools that they reviewed, only 9 still had a formal accommodations policy, and 8 they had either no policy or a draft-only policy. So we are still in evolution in Canada across our medical schools, in terms of how well we're actually doing what we're supposed to be doing on the accommodations front. I think also if we go important, every nation has its own human rights codes and principles, but I think in Canada, just to remind that disability is a protected ground in our federal, provincial, and territorial human rights codes. And this code protects the rights of people with disabilities to obtain reasonable accommodations to allow for equal, not enhanced participation in activities, including education and work. And as the Human Rights Code has outlined, very specifically in post-secondary education, there is no requirement that academic standards be reduced or ignored to provide accommodations, and that's the trainee's responsibility to meet the essential requirements of the course or program. But of course, accommodations must be provided. And also they note that accommodations can be requested retroactively after the fact, which in past was a point of some contention and question in the past. So if we think now, move into a bit before Nadine's going to speak a little bit about what are the barriers, some of the barriers and the issues that residents face when they have a disability and are seeking accommodations. I just want to talk about I think frankly, talk about some of the challenges that we face in as somebody that's providing accommodations and working with residents and with program directors and supervisors to develop accommodations plans and implement them. these are some of the things that some of the barriers and the challenges that we encounter. So things like overtaxed systems and supervisors, we have a very busy, complex, and under-resourced system in Canada. So we hear from program directors things like, well, we don't have the time or resources to do this. We can hear sometimes skepticism about the accommodations process. Like, why is this accommodation needed? Is it really needed? Is it really justified even? Sometimes programs and specialty cultures, they'll say things like, well, we don't do that here. And that's never been done here. We've never had to provide accommodations to a learner before. And why now? What used to happen? We can sometimes see a lack of flexibility within programs. Like they'll say things like that, well, there's only one way that residents can meet this objective or meet this expectation. And that's the only way there is. Sometimes there's tensions we hear about amongst peers and residents. So residents will voice or just feel or express privately concerns that it isn't fair if one resident has accommodations, that's going to mean more work for me. Some of the other issues we face when we're trying to introduce accommodations are the culture of medicine. We hear people saying things like, those residents just aren't going to cut it. We've got to prepare them for the real world they're going to face when they get out. Or I've had to do work through my disability or my health issues on my own. Sometimes, especially in the context of invisible disabilities like mental health or neurologic or other autoimmune conditions, for example, people can't see the disability. And so they will ask questions like, well, how do we know this is real? How do we know that the resident is being straightforward and transparent about this? And so, of course, and also it can be complicated when there are academic challenges paired with disability to understand which are the issues that are related to disability and which are related to academic challenges. And of course, any resident, disability or not, can have academic challenges, but these can add to the complexity. I think we bring these forward just to be very straightforward about some of the environments what we find ourselves in as we try to introduce accommodations programming and accommodations to the medical world and to academic medicine. But we are confident that the belief systems and the culture can change. And so Nadine's now, I'm going to turn it over to Nadine to introduce herself and then to talk a little bit about some of the barriers that she and other residents have experienced that we can hopefully keep in mind as we try to move this work forward.
Great, thank you. So my name is Nadine and I'm a family medicine resident who honestly has found themselves in this space purely out of necessity. I was somebody who received their acceptance letter to medical school and their official medical diagnosis in the same week. But it wasn't until residency that I actually became confident in, understanding my needs and working with resident affairs. So I'm really happy to be here. And just as a disclaimer, a lot of the examples I list are not all my own. I just want to give thanks to the medical students and residents that helped put these together and the crowdsourcing that I did for that. So really, these next few slides, my intention is really just to ground our higher level conversations about policy with the realities that we as residents with disabilities face and why we need this type of institutional support, because we still experience microaggressions and ignorance throughout our training. And whether that be intentional or unintentional, whether that be from staff or colleagues, these are real things that residents living with disabilities have experienced. So for example, you show up to a shift and you explain to the staff that you're working with that, you have a modified call schedule, so you'll be leaving a bit earlier. Staff have responded calling that, oh, you have a baby call, or, oh, you're on the princess shift. And, that's a type of, it's very belittling, it's very demeaning, and it's hard to experience that type of interaction and then furthermore proceed with your shift. Some of these examples are a bit more subtle and some are more overt than others, but in my case, some of these interactions would dictate my future likelihood of even enacting my accommodations. So, I was lucky that I actually had a plan, and even I hesitated to implement the plan based on the type of interaction I had with a staff or with a peer, because it almost felt more traumatic to ask for my accommodations to be respected than to just go without them. And, these are the type of, mental and emotional calculations that are quite difficult to carry on top of, learning new medical concepts, working with a new staff member, carrying your personal life, all the things that everyone else is doing. So I have these listed here just to share, some of the extra load that residents with disabilities are experiencing. So if you go to the next slide, really I want to point out here is, when seeking career advice, some residents have actually been redirected to just consider their profession entirely, or really met with some, uncreative solutions. And I have to say, most of these things that are said are out of fear usually, or ignorance, not sure even how to provide advice, not even aware of the modifications that exist that can help a trainee proceed with that type of residency. So really, this type of barrier is so important to recognize, because it does tell us what we can do in our policies, or what we can put in place to support residents. Because having a staff person that is very coherent in these topics, or has a lived experience of a disability themselves, they wouldn't meet these questions with, oh, like, can you do something different? Like, that sounds really complicated, because they know about all the different options. So really, we need to have people who are ready to embrace residents and trying to be helpful as opposed to being harmful. And how can we do that? Well, we can provide institutional support for these residents by also supporting the types of people that would deliver this advice. So if you go to the next slide, I'm not going to read all of these out, but I just want to highlight a few suggestions. So the right-hand column is really just overarching ideas that I believe need to be reflected in policy and in processes that will reduce the barriers. So one of the most important starting points, in my opinion, is the use of disability-focused inclusive language. So I know in these circles that probably sounds rudimentary, but I'm thinking of, in the delivery of medical lectures in medical school, in oral presentations in front of colleagues, rounds on the hospital floor about patients, walking towards the physician lounge, going for coffee. These are the places where our language must be intentional, and it must be inclusive, and it should not be carrying ableist language. And how can we do that? Well, there are inclusive language guides that have been published. And there are ways that we can disseminate those language guides ahead of time to lecturers or preceptors, or we can call on leaders of departments to actually make a statement about inclusivity, and to speak about the fact that there are residents in this program that have accommodations, and to really just break that taboo, because that would show that it's an important part of our workforce, a diverse workforce. We have residents and staff alike that have accommodations, and that's what makes us great. Having that type of statement from the get-go is really important. Another thing that we need to do is have residents feel safe, that when there is an incident, that they know where to go to report that if needed, if there is mistreatment. So not only understanding their rights, but where to go to get help, and have that reassurance that it won't affect their career. And so we can go to the next slide here. So if we want to go to the next slide, yeah, great. So how can we actually reduce these barriers for residents? Well, we can reduce the administrative and the financial burden by having some of these options on the right. We can standardize documentation, medical documentation, information that's being passed on. We can have knowledge of different funding streams that might help them. Because what's important to remember is that residents, when they start their program, we're just inundated with so much information, especially in orientation. You get about your hospital badge, your rotation schedule, your exams, and residents with disabilities have this added layer of having to know where to navigate all this other information, like, where would you go if you needed accommodations? What about the legal options are available to me? Are there disability funds and research grants that might benefit me? Is there an appeal process? Like, there are so many things that we don't even know exist. And having a dedicated staff person, so a disability specialist or some form of navigator, that would be very helpful here, because they would be very well versed in these extra topics, and that person could help navigate the resident and really discuss the implications of what it's like to have accommodations. So for example, being off cycle as a resident, that has implications of not graduating with your cohort, having solid salary modifications, not being eligible for certain loans if you're considered part-time as opposed to full-time. Just really providing insight into the potential implications, but also benefits of having accommodations, because you can proceed in your training safely and successfully. So I think that this is an important way that we can support residents. Another really great thing that McMaster is doing is having an actual staff person with a lived disability, being available for residents. That representation in your field not only provides hope, but it's also a very practical avenue for discussion. Having that clinician with a disability tells us that it's possible. And that transition from resident to staff is a very unique one too. And that's a whole nother conversation, but having access to that is very, very important. Having access to disability focused conferences and research rounds such as this, or, I believe tomorrow Stanford's 5th annual disability conference is available. I'm doing a research year myself next year, and that's self-designed, and it's about disability. That's an opportunity that I think is very supportive. And another important piece of supporting residents is acknowledging the fact that there are other residents with no disabilities that are affected by this. So we have to ensure that we're supporting them too. So if call is being modified for people with disability, are the other residents feeling supported? Are there, attendings available on the floor? Are there physician assistants? Are there templates? How can we support making this a healthier work environment for everybody, and really just working and walking towards more universal accessibility? And then if you go to the next slide, some of these things I've already addressed, but what I really want to emphasize here is that access to materials is so crucial. Having not just on the website, or during orientation, but is it in the resident handbooks? Is it in the bulletins? Is it in the emails? It should be so clear that it's hard to miss, not hard to find. And I think that it cannot be understated how important it is to just constantly have these multiple checkpoints and platforms about accommodation policy and processes, because they are inherently confusing. So they need to be clear, and they need to be in really obvious places. And the last thing I'd say is that, it's important to really involve the resident and ask their preference for the way that their accommodations are being communicated. Some residents prefer to communicate their plan themselves. Some prefer the rotation coordinator to be notified ahead of time, and for that plan to be disseminated ahead of time. Instead of the person finding out on the day on their rotation, who knows what, that should already be determined. So for me, I would rather have my plan ahead of time be disseminated, as opposed to me showing up to my shift and catching the preceptor off guard. But that's something that's really a preference. And I think that if we just ask the resident what they prefer, then that would be very supportive for residents, and we would reduce barriers and the stigma that we feel that we'd experience. Yes, we can move on now.
Thank you so much, Nadine. I'm going to walk us through McMaster's particular policy, as I've already been introduced. I just want to say that, when I hear Nadine speak, I'm reminded of the reason I got into this work. And it was when I was working in the clerkship space and was tasked with working with all of the learners coming into clerkship who would require accommodations in the clinical learning environment. And I learned so much from them, and they were so generous with me at the beginning of my journey, when I was pretty naive to all of this, because unlike Catherine, I was not an occupational therapist by training. And so it was a real journey. I have had my own journey with disability on a personal level, but really only as a staff member. And I think it's quite different than as a trainee. I just want to encourage everyone to either go to the link in the chat that Dr. Meeks put in, or to use the QR code to have access to our documents. As I walk through our policy and processes, I'll also direct you to some of the documents that I'll be referring to on the slides. I want to mention as well that we really see this as a work in progress. We're by no means done. The implementation of our policies and processes are still very much an active endeavor. And I'm excited to say that Drs. Carolyn Bowman and Jennifer Ham, Jennifer is a resident in our programs, are leading a project called Resident Health Matters to explore barriers that residents face and work to mitigate them at our own site and setting. And we're excited to see where that work will lead. So I'm just going to remind us all that we provide all of the different types of accommodations in postgraduate medicine. I'm not going to go through the definitions here, as I suspect they're quite familiar to this audience. So we've developed a 5-phase accommodation plan. So we first of all have the submission of the request, the assessment of the request, the development of the plan itself, implementation and communication of the plan, and maintenance and monitoring of the plan. And I hope as I go through these things, you'll go back to some of the words that Nadine shared, because we really have tried to take into account the voices that we hear from learners in how we've designed this process and are continuing to implement it. So let's walk through this, thinking about this through the journey of an internal medicine resident named Anjali. I'm going to take the role of her accommodation provider as I walk you through as her internal medicine program director, which I'm not, but I will be the fictional one. So she's a third-year resident who's had academic struggles in the program since she was in first year and has undergone remediation twice. She recently provided me, her program director, with documentation for the first time indicating some functional impairments, which include poor concentration, difficulty with organization, planning, and time management, and difficulty with sleeping and waking. The following accommodations were sent to me by her healthcare provider to be reassessed in 3 months. She needs an increased amount of time per patient seen. She needs a reduced number of patients if she's in the clinic outpatient setting. She needs templates to assist her with documentation and a reduced call frequency down from an average of 1 in 4 nights to 1 in 5 nights. So let's talk about the principles of submitting the request. So if you go to the linked files, there's a folder called Trainees, where you can see a document called Accommodations Healthcare Provider Documentation. So when we're considering this in our own process, we're thinking through the lens of where is this information? Is it easy for Anjali to find it? Is it easy for her to understand it? We have chosen to try to pick multiple access points from websites that are used by residents for other sources of information in the program and link them all to the main source. I would strongly suggest as you're thinking about this that you don't have all of your documents in 10 different places, because then when you update or change a document, you have to remember all of the places you put it, and you're very much at risk of residents not having the latest, best information. So what we do is we link to sort of the source of truth from multiple different sites, and we try to introduce it, as Nadine alluded to, in many different places. We're actually working right now, Dr. Bowman's been tasked with working with some of the program directors to provide this information to residents before they even start the program in their first year. And we're working on ways to do that and do that better all the time. When Anjali looks for this information, how does she know where she can find support in the process? We try to make sure that residents know right from the get-go that Resident Affairs is always there to support them. Importantly, does she know early in looking at all of this that she does not need to disclose her diagnosis? She does need, of course, to make sure there's a well-described functional limitation, and the accommodation provider will need to understand that. We suggest using a template for care providers that guides them to give you the information you need to sort of stop some of the back and forth that will inevitably happen if healthcare providers aren't sure what information you need. And make sure as you're working through all of these steps that you deal with this in a confidential way and you have a secure way to store trainees' personal information. So the next phase is, how do we assess the request? This is kind of, I would say, the most complex part of the entire process in many ways, because if you get this part right, the other steps are a little bit easier. And if you don't, it can be a little bit more difficult. I'll direct you to the provider folder where you can find actually 3 documents: the flow chart, the checklist, and there's also an explanation of the checklist document. So we think back to Anjali and assessing her request. Does she have a functional limitation from a disability requiring accommodation? Yes, I believe she does from the information that I've received from her healthcare provider. If, on the other hand, you are wondering whether or not this is something that might require an accommodation on a different basis, you should direct the trainee to that person or reach out to something like your resident affairs office to get more information. Is Anjali's accommodation request clear, and do we have enough documentation to be able to move forward? I believe we do in this case. If you figure that you're in a situation where you're not sure or you need more information, for example, from the healthcare provider, consider at this moment starting some interim accommodations. We're actually duty bound to do that, first of all. But second of all, I think it's the right thing to do. By not doing that, and we create more barriers and delays for the learner, and we actually potentially put them at risk of not meeting the requirements of their program and having them lose faith in the processes that we've set up. So we really try to encourage people to put interim accommodations in place, clearly ensuring that the learner understands that they need to be modified moving forward once that further information is obtained. Is this a standard request? Does it need fundamental alteration? For Anjali, this seems to be a very standard request and we can move forward. And again, if there's some discomfort here and you're not sure, you don't think it's standard, then determine which parts of the request you could put into place right away as interim accommodation, and then continue down your pathway of getting more support. So then we move to, if we grant this request, could this compromise Anjali's ability to meet these areas, like the essential requirements of her program, the licensing standards by our provincial licensing body? In this case, no, it really shouldn't. And again, the answer always is, if there's some concern, bring this to the next level and make sure you have a thoughtful and careful process about thinking through whether or not this is actually the case. Could the accommodation compromise patient safety or care? In Anjali's case, no, it really will not. So we can proceed. And if there's a sense that patient care or safety could be compromised, this requires some teasing out. And this is where we would use our postgraduate medicine accommodations panel, for example. We would include the program director. We might include the program director of a similar program from another university. We might include some occupational medicine or therapy specialists. We might really think about the context of the learner's training, because what might compromise patient care, for example, in a rural setting, might not compromise patient care in a better resourced healthcare setting if the resident was placed there. So we want to really think about this in terms of the resident as a learner and not just a provider of healthcare, and really view that individual's context. Could this accommodation result in significant costs, either financial or administrative, to implement? Or does it cause undue hardship to the university? Notice here that I've said the university, because the bar that is set in Canada, and I believe this is similar in most, if not all, and other jurisdictions, would be not the level of the internal medicine program, not the level of postgraduate medicine at McMaster, not the level of the Faculty of Health Sciences, but at the university writ large, and potentially at the hospital or hospital system as well. So, again, if an individual perceives some barriers here, I would strongly suggest that that individual does not bear the burden of that decision, but that it is brought through the necessary channels by folks who are well acquainted with what is required by human rights legislation. This tends to be a good driver of change. There has been some very clear precedent in Canada and in the United States when institutions have decided to use this, where the human rights commissions or the courts or whatever the correct body is in that area, that the bar is very, very high here, and that our duty is really to accommodate. So overall here, Anjali's accommodation request is very reasonable, and now my job as the accommodation provider and her program director is to work with her to develop a plan. If there's a sense the criteria have not been met and the trainee cannot be accommodated at this time, really need to, again, think through some of the things I've said there to make sure that you have a thoughtful and equitable process. Make sure you have some sort of way to bring in other people, that this decision does not rest with a singular individual. And I like to also point out that it's important that there's a big difference to me between negotiating accommodations, which is what we do not do. We accept that the learner needs that accommodation for an equitable environment, but we can do a lot in navigating accommodation, which to me means tailoring that accommodation to the resident, the program, and that learning context. So when we go to the next step, which is developing the plan, I'll direct you to the provider folder where there is a file called Accommodation Plan Template. So the things we're thinking about here are, do you have all the information? We've kind of run through that in the assessment piece. And if you've got it right, then you will have all the information you need. Sit down with the learner and find out, in this situation, let's say Angeli actually had accommodations in clerkship, but chose not to use them in residency. And it might have been one of the difficulties she's been having. So talking to her about different strategies and plans that she's used in the past, get creative, be flexible, use a template, adhere to that need to know principle, and really make this a collaborative approach where, as Nadine spoke about, making sure that the learner is on board with you and you're walking side by side as you develop this plan before finalizing it. If you're not the program director, make sure the program director is involved, because they need to make sure that the context of that training program is considered. Finally, implementing and communicating and maintaining and monitoring the plan. There are some files here in the accommodation guideline for providers that can walk you through some of the principles we're using. So I'm just going to give a little example of what I would do as her accommodation provider and give you a little excerpt of that. So this would be my communication to the rotation director for her upcoming 3 months on internal medicine inpatient. So I would ask that she have these accommodations implemented, and then I would ask specifically that this would be what would be communicated to her clinical supervisor. Now I've put the whole list here, but actually I would like to point out that all I would send would be this increased time per patient. I'm her program director. Our office actually makes the call schedule. So the clinical supervisor does not need to know she's on a modified call schedule. Angeli and I have worked together with our EMR to make sure she has templates for documentation. We've developed a good plan there. So again, her supervisor does not need to know that. And she's not in an outpatient setting, so they don't need to know that she needs a reduced number of patients in clinic. So this is upholding those principles of need to know and communicating to the right people with the right information. Make sure you have consent from Angeli, and if you look at our template, you'll see a spot where the learner signs it so that they know what's being shared. And again, consider modifying that template depending on the audience, or taking excerpts from that template depending on who you're sharing with. Make sure you are not including details about the cause of disability, the diagnosis, the symptoms. Those are not needed to be able to share an accommodation plan. And when learners are leaving your program, use a template with clear instructions about who and what is shared. Maintenance and monitoring. So in this situation, Angeli is going to do a 3-month rotation, and it needs to be reassessed by the end of that. So I'd be setting up a meeting with her already 1 or 2 weeks into the rotation, maybe at the middle point, and then maybe 4 weeks before the end, to be able to sit down with her and see how things are going and find out when is her appointment with her healthcare provider. How's that going to be reassessed? When does she expect to have that information? All plans need at least an annual review, and you really, as Nadine pointed out, need to look to the trainee. We hear from learners with chronic disability, with stable situations, that when they're asked all the time to reassess their accommodation, it gets in the way of the work they need to do. But having a touch point with them and saying, hey, I'm just checking in. Is anything changing? Do I need to be aware of anything? Do we need to discuss anything? Just give me the thumbs up, or, we'll leave it alone, kind of thing. And all the learners, the program directors, all of the people in this process need to know where they can go if things are not going according to plan. And in our case, that would be the Resident Affairs Office. I just want to end up this section by saying that, even though we've spent a lot of time kind of talking about accommodation in quite a technical way, this group really believes that true accessibility is much more than this. We want to see a scenario where there is more of a universal approach that is proactive and removes and prevents barriers to participation. It doesn't require learners to constantly be self-identifying and outing themselves, creating all these barriers for them in proceeding through their training programs. And we'd like to see things be more proactive and less reactive. And we really hope over time that as we increase true accessibility, that the need for accommodation will actually go down. And in fact, the burden on institutions, if you want to think about it in that way, will actually decrease the more accessible our clinical learning environments become. I just want to thank you for your time, and I'll hand it back over to Dr. Munn to wrap up.
Thanks, Jill. So if we go to the next slide, I think just to end on to say, I thought it was a powerful article we linked below that talks about moving from disability to possibility. And there's many other examples of that, but I think also the quote we sort of find inspiring is, there's only one way to look at things until someone shows us how to look at them with different eyes. And I think learners are constantly showing us how to look at things with different eyes and a different lens. And also those of us working in this space also really have to guide others to see things through a different lens and in a different way. And we can bring them on side and on board gradually and deliberately. And moving just to the very last slide, just to say, we're really appreciative of you coming to hear us today. We're always happy to speak about this further. We are open to questions, as Dr. Meeks indicated, and we've attached our emails here if you want to reach out to us at any time to follow up. And we'll just stop there. And thanks for being with us today.
Well, I think everyone in the audience can see why I immediately ran up to all of you after your workshop at ICAM and said, please, please, please come and present at Dream Rounds. This was amazing, and I've learned so much. I'm so excited about what you're doing in Canada. I want to briefly tell our audience, thank you for bringing up the Stanford event tomorrow. I want to remind all of our audience members that the SMATI, or Stanford Medical Alliance, blah, 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 is having their annual event tomorrow, and you can still register for that. And our next Dream Rounds will be on June 27th, and that will be with Dorothy Tolchin about preparing the physician workforce to provide high quality care for patients with disabilities. So we have just about 6 minutes left, and we do have some great questions. So if we don't mind stopping the recording, and I just want to thank you all so much for your time and this incredible presentation. And I'll wait for Caroline to go ahead and stop recording. And we'll move on to a question that I think is really on everyone's mind. I know I hear it at all of